CMS tells us that 55% of heart failure patients with a coding for heart failure have 5 or more comorbidities. That can affect outcome, it can affect treatment, certainly, and that is why in the December 2nd issue of JACC, we have a paper on the non-cardiac comorbidities in heart failure with reduced versus preserved ejection fraction. It is a state-of-the-art review, and I'm with the author, Robert J. Mentz, MD, Assistant Professor of Medicine and Director of the Duke University Cooperative Cardiovascular Society. This is really a hard issue to deal with, and it's one that we don't necessarily have a lot of guidance on. So what was the impetus? Why did you do this paper, first off?
So I've been fortunate to be involved with the Cardiovascular Clinical Trialists Forum, which is led by Drs. Bert Pitt, as well as Fayez Zanad. And it happens every year, and actually this year will be the first time it'll be in Washington, D.C. But last year's meeting was in Paris, France in December. We had the opportunity to pull together a number of leaders in the field of heart failure and to have an open forum to talk about this key issue of comorbidities in heart failure and the potential difference in terms of the patient profile and outcomes in reduced ejection fraction versus preserved.
I mean, this has become a real hot topic in the last few years. So in terms of comorbidities, what did you find?
So the discussion we had was looking at some of the commonly recognized comorbidities. So certainly renal disease, diabetes, obesity, anemia. Then we also expanded further and looked at sleep disordered breathing, which is increasingly recognized for the important role that it plays in our heart failure patients.
Now, did you find there was a difference between whether you had comorbidities relating to preserved ejection fraction? Were you more likely to have certain comorbidities versus reduced?
So I think the general finding was actually comorbidities are so prevalent regardless of whether your ejection fraction is preserved or reduced. But we did find that there were some comorbidities that were more frequently seen at a higher percentage in those patients with preserved ejection fraction, specifically COPD or obstructive lung disease, as well as diabetes and anemia.
Now, is this to the point where if you see a patient, you might want to check more for those particular issues if they have preserved ejection fraction?
I think it's certainly in the case where if you've got a 15-minute office visit with a patient, as a heart failure cardiologist, a general cardiologist, our focus is on the heart. Correct. And I think the recognition based on some of this work is how important these comorbidities are. Maybe providing a greater amount of time to discuss their lung disease, their anemia, and how all of these factors are influencing their heart failure management as well.
Well, I said at the top, it can affect morbidity and it can also affect the things you choose to deal with these patients, to manage them. What are some of the specifics that you would suggest?
So I think I would highlight COPD as an example. So quite common concomitant comorbidity in patients with both preserved and reduced ejection fraction, potentially an increased prevalence in those patients with heart failure with preserved ejection fraction. I would highlight the case of beta blocker use. There's been a long-term appreciation or a perspective that these medications are contraindicated for our patients with heart failure. I think there's a growing body of literature that suggests that our patients should be receiving beta blockers when they do have concomitant COPD safely, monitoring them closely as these medications are initiated. And at present time, there's the perspective that the cardioselective beta blockers, I think, would be one example where we see preferential use potentially in those patients that have both heart failure and lung disease. And what I'd suggest is that I think there's growing literature to suggest that if patients for one reason or another are not able to tolerate the cardioselective medications, there is evidence that those that are classically thought as non-cardioselective may still offer the similar benefits in those patients with a similar tolerability profile. So I think the take-home message would really be realizing the perspective of these comorbidities, but also that we need to try to maximize their therapies for their heart failure as well as these other illnesses.
Guidelines do a wonderful job of focusing in on the heart failure, but in terms of comorbidities and how to handle things, not necessarily. Where's the clinical guidance going to come from for this particular issue that you are addressing in this review?
So I think that's a very key point, is that certainly in heart failure guidelines, the focus is on the sole disorder of heart failure. And I think we're fortunate that the more recent guidelines are really starting to emphasize these comorbidities, particularly in preserved ejection fraction, where the pharmacologic therapies aren't there to target their heart failure. So potentially really emphasizing these comorbidities could be an opportunity to improve our patient outcomes.
And this state-of-the-art review is at least a start.
That's right, I hope so.
And that's in the December 2nd issue of JACC. So if you would like to check that out, along with a variety of other major papers, please do so. For CardioSource World News, I'm Executive Editor Rick McGuire.